Hi everybody, this is Rich Wolitski, and I'm here at USCA in Washington, D.C. We just finished the federal plenary where we heard from leaders across the federal government about the work that's being done to prevent HIV, provide HIV care and treatment. And with me here today, I have Dr. Jonathan Mermin, Director of CDC's National Center for HIV, Viral Hepatitis, STD, and TB Prevention. It's been a little bit since I worked there, but I got it all out still. That's good. And Dr. Dr Cheever, who's the Associate Administrator for HRSA's Bureau of HIV/AIDS in HRSA. So a little awkward with the introductions today, but I think we'll do just fine. So I wanted to kind of start off with asking both of you to give us, in the audience, a little bit of a recap of what you talked about to the USCA audience. What was the most important things, or two things, that you had to share? Laura, I'm going to start with you.
Oh, I think the most important things were, one, that we do have good improvements in viral suppression in people that are engaged in care in this country. Mm-hmm. In the context of the Ryan White program, which is really care for people that are underinsured or uninsured, we've improved viral suppression rate from about 69% to 83% over the last 6 years. We still have disparities. We've reduced the disparity gaps across the board, but we still continue to have disparities that we need to address. And more importantly, we need to address the viral suppression rate among those people that aren't in care. Mm-hmm. So we need to do a better job as a program of reaching out to those people who are not engaged with us, getting them engaged, retained in care, and on medication.
Yeah. And that's hundreds of thousands of people.
Hundreds
of
thousands.
A large number of people who need to be in care, who aren't, and we'll probably be coming back to that one in a little bit. But John, let me give you a chance. What are some of the highlights that you had presented?
Thanks, Rich. I really highlighted 2 points. I mean, the first was, how did the nation respond to new science starting about 5 years ago? We've got increased information about the effectiveness of antiretroviral therapy to help people live longer and healthier lives and to decrease the transmission of HIV infection, and also the importance, because of that, of diagnosing people with HIV. We also saw new introductions of PrEP, which is pre-exposure prophylaxis, which, if taken once a day, a pill, prevents people from acquiring HIV infection. So I presented information that showed how the nation had changed. We shifted the focus of a lot of our work to help diagnose people with HIV and also to link them to care and then essentially hand them off to the care system to help them stay in care, but if they fall out of care, to try to re-engage them. I also talked about what that meant. Well, we've seen decreases in mortality rates for people with HIV in the United States, and we've also seen what we estimate to be 33,000 fewer HIV infections over a 6-year period than we would have seen if we hadn't been responding effectively to the epidemic. And ultimately, those infections would have cost the nation $15 billion of healthcare costs over the lifetime of those individuals. However, it wasn't a perfect situation. We've also continued to see dramatic disparities, both with incidence of HIV being much higher in African Americans and Latinos and Native Americans than white Americans, and also seen some continued disparities geographically and in mortality rates.
And one of the things I did in my presentation was highlight some of the data that came out from CDC that are used to monitor the National HIV/AIDS strategy. And one of the indicators I didn't mention, but since you brought up PrEP, I wanted to call it out here, is that we saw a 300% increase in the number of people who were using PrEP. But we also know from other studies that, going to the disparities point, that the uptake is happening more among white people, and we're seeing less uptake among black, gay, and bisexual men, for example. I know CDC is doing work to improve that. Can you talk a little bit about that?
Right. So Rich, that's true. So we always want to do a two-pillared approach. We want to maximize our impact and we want to reduce disparities. And I've reflected on when antiretroviral therapy was first introduced into the nation. Everyone benefited. We saw over an 80% reduction in mortality, but you saw an increasing disparity in death rates between African Americans with HIV and white Americans with HIV. So everyone benefited, but some benefited more than others. So when PrEP came out, we hoped not to see that same experience, in this case with access to pre-exposure prophylaxis. So there is a benefit to a greater number of people in the nation, but there's certain parts of the country that haven't embraced its use, certain populations that are still need to know that it's working well and how well it's working, and we need to introduce support systems that allow people to both learn about PrEP and to access it. Some of the issues as clinicians as well.
Yeah, and also navigating the reimbursement systems, and it's not as easy to do as people might think. And I know that HRSA is prevented from providing PrEP to uninfected people, but you talk to your patients about it in the clinics, right?
Oh, absolutely. So I think in the context of the Ryan White program, we can't use our funds to fund PrEP, but certainly in the context of HRSA, the larger organization of HRSA, we have the community health centers where PrEP could be prescribed. And certainly clinicians are discussing PrEP. I think part of it is something that really gets to the core of the Ryan White program, which is you need a broader public health approach in terms of the implementation framework for PrEP. That is not going to happen between a clinician and a patient by themselves. That if we have a broader framework where you're thinking about doing needs assessment, where are the gaps in the community and how to fill those gaps, working with health departments, we'll get much further, much faster, and I think that's what CDC is also working on.
If I could just add, it's actually a perfect description of, Dr. Cheever runs an organization that is focused on helping the clinical setting do a better job. And at CDC, we've tended to work at the outer sections of public health, often people who don't have HIV or people who have HIV but don't know it and try to get them tested. Both of us are working to share the universe and understand how we can benefit each other. So us spending more time relinking people to care and understanding what's happening in the clinical situation that people are falling out of care and potentially not accessing the preventive measures that they can use. And then obviously what Dr. Cheever is saying is that is helping the Ryan White system expand its vision to understand what it's like for people who have HIV infection but actually either don't know it or are not in care at the same time.
And having both of you here together, I think it really represents kind of how CDC and HRSA are starting to work more closely together over the past 5 years or so. And I think we see that in the joint community planning and also in the work that's been done for data to care, to use surveillance data to bring people who've dropped out of care back into care. So Laura, from your perspective, what has happened in that arena that's been most helpful and most useful to you?
Yeah, I think the most important thing that's happened is our providers, both at the health department and at the clinic level, understand the importance of data. They need to understand if a patient hasn't come back to care, they can't wait a year to figure out the patient's lost to care and try to find them. They need to have their data in real time to be looking at who has missed appointments and to have mechanisms to go out and reach them. A lot of time those mechanisms may be based in the clinic, but equally they might be based in the health department. So there are a variety of ways of reaching into the community for those people that haven't walked into the clinic door, and we're doing a much better job at that, but we have more work to be done, and we're working with CDC on it.
Yeah. And what about from the CDC side, Jono? How's that been going from your perspective?
Well, Rich, I think the first line of action is going to be the clinician himself. They're going to try to reach out to patients to try to bring them back into care, to find out whether they moved or what happened, how they can really make it a more inviting environment. But if someone's really lost to care, the public health system needs to come into play. And so we have found it very productive to use surveillance data that says a person hasn't gotten a viral load or a CD4 count. There may be something up, and then to try to reach that person and find out what's going on so that we can assist them back into care. So we've seen some success. I think the issue that Dr. Cheever brought up, which is that sometimes it's just too long a period. It can be over a year for the time when someone's fallen out of care. So some of the creative work will be working with pharmacies and other kind of systems where we can find out if someone hasn't picked up a prescription. That would be an excellent opportunity to then reach out to someone early on and find out what the problem is.
Yeah, it seems like also we talked about in this session about the importance of people's motivation for coming into care and staying to care themselves as a person living with HIV. And certainly the new data on viral suppression as an effect of HIV treatment on preventing transmission of HIV sexually is one potential motivator that people may have. How do you see that working in the Ryan White program?
Right. Well, I can speak from my personal clinical experience. I had several patients that for years with highly effective treatment really didn't want to get on treatment. They were worried that one patient literally told me, I would rather die than have my family find out I have HIV if they had their medications in the drawer or something and someone found it. When we started that discussion about, if you are on treatment, it is unlikely you will transmit HIV to anyone else. That changed several of my patients' minds. And I've got to say that all my patients now are on therapy. And for several people, it really was that understanding that shifted that balance between their fear of stigma and discrimination and their wanting to be on treatment.
And CDC has done some modeling work looking at the contribution of treatment as prevention with viral suppression. And it turns out to be really, really important when it comes to preventing HIV infections. What do those data show, Jono?
Well, exactly what you said. They show that essentially if we can help people get diagnosed pretty quickly from the time they have their infection, and then taking ART very quickly after that, we could dramatically reduce the HIV epidemic in the nation and help people live longer and not transmit to others.
And I think, and correct me if I'm wrong, but I think it's the single most important strategy when it comes to preventing new HIV infections. Is that true?
It
in
is.
terms of numbers?
It is,
what we
Rich.
can achieve?
It is.
Yes, I think that's an important thing for people to keep in mind. So often we've sort of segregated treatment and prevention, and we said they're two different things, but really now treatment is prevention, and they do belong together, and they can make a huge difference on the course of the epidemic. So one of the things that sadly is still a real problem, and it's kind of part of the reason I'm wearing this shirt today, is the stigma and the need for people to stand up, to speak out against discrimination and stigma that exists out in the world today. And we hear about it happening sometimes in health centers, community providers, and in all kinds of other settings. What are you doing, Jono, in your programs to address stigma?
Well, sometimes you can address stigma directly, and sometimes you can actually reduce it indirectly. And so what I wanted to really highlight was what I'm seeing at this conference. There's actually remarkable movement to really highlight the importance that taking antiretroviral therapy and having an undetectable viral load makes someone feel better, less stigmatized, feel like the fact that they are not going to be transmitting HIV to others, that they present no risk to people. He already knew that casual contact doesn't transmit HIV, but this now brings it to a different level where people feel so much closer to people who, and sharing information, as you highlighted, it really can make a big difference.
And what about in Brian White program?
So I think similarly, certainly our providers are sending that message. We just surveyed them informally and found that at least 80% that's a core part of what they're doing as they educate patients. So that's definitely an important part of it. But I do think that we need to do a broader engagement in community. I practice in Baltimore, which has had a lot of HIV for a long time in East Baltimore, and still a lot of my patients are required to eat off of their own plates in their household, that if they go to the bathroom, they've got to clean the whole bathroom with bleach. That is still happening. And that's not going to happen by a person with HIV knowing that they're not transmittable. That's a broader societal engagement that we need to have.
And it speaks to the need for campaigns and information that goes out not just to people living with HIV or their providers, but also the general population. And then also, too, that you're starting to monitor stigma as part of the MMP or NHBS.
Right, we are monitoring stigma. And I also think that some of what Dr. Cheever raised is also important. Clinicians matter. And what we found in some of the studies where we've asked people who've fallen out of care to get re-engaged in care is that they fall out again. And in some circumstances, that's not what's happening to them outside the clinic. It's how they feel when they're in the clinic. And so having a welcoming environment, and really a comfortable environment, which is what doctors want with their patients, sometimes doesn't happen. And so really encouraging that, I think, can also decrease stigma as well.
Yeah, and I think that part of the issue is that if you say, okay, give me an evidence-based intervention to change the way the clinic functions, that doesn't necessarily exist. So we at HRSA have been working very closely with looking at our clinics that have had a great deal of success and finding out what they're doing and comparing them to clinics that aren't having the same success and seeing what those differences are and packaging those up so that we can spread those successful interventions to other clinics, even in the absence of having a randomized clinical trial. So that is actually an effective strategy we've been working on the last couple of years.
I think that is so important because really you've got excellent centers and you've got people who are doing an excellent job and you need to learn from them.
Right.
So that's really great. So I think we're kind of getting close to near the end, and before we finish, what I want to do is ask both of you to think about what other points did you make today that you really want to make sure that our folks on Facebook Live have a chance to hear about. So whoever's ready first can go first.
I mean, what I would say is I was talking with a woman right before my talk, and she had talked to me about how she had avoided getting an HIV test because she was both fearful of what the test would tell her, but also of the implications for her ability to feel comfortable being with others. And that she got a test because she had heard about the incredible benefits of ART. And I think if I were going to really highlight issues, it's that we really need to reduce those barriers so that it's pretty regular for people to get an HIV test, just like a cholesterol check or a blood pressure monitoring whenever they go into the clinic, and that we link them immediately to the treatment that they need instead of waiting the periods of time that we used to wait.
And I'm going to jump in there and I'm going to give you kudos because in the new CDC funding opportunity announcement for health departments, I was so impressed with the vision and the leadership that the CDC showed in that FOA in requiring that when someone tests HIV positive, they're linked to care as soon as possible. And I think what you mean by that is with either that same day or the next day, whenever possible.
That's ideal.
Yeah, and so this goal of within 30 days really represents kind of the outlier that gives people enough time to go back and follow up with people if it hasn't happened within that first week.
Exactly.
So I think that sends an incredibly important message to people living with HIV, that this is serious and you have to take care of it right away. So Laura, what about you? What last words do you want to kind of get into the audience?
Yeah, I think one thing we haven't talked about here that I talked about extensively are those structural barriers to care and how we as a nation address those. So people that are homeless are going to have worse health outcomes, whether it's HIV, diabetes, managing their asthma. So what can we do within our medical programs to help link people to those other important programs? So we, in the context of the Ryan White program, and using funding from your office, the Secretary's Minority AIDS Initiative funds, have been able to fund, for example, this year, a program where we're linking through our case managers and our outreach workers people to other employment services that exist. Because if someone is going to live in poverty, they're going to continue to probably to have larger health disparities. Then if we can help them get employed, improve their socioeconomic situation, they're going to have better health outcomes. So that's critical. We're doing that both in employment and in housing. Important work that we need to think about more broadly in this country if we're going to address this HIV epidemic.
And as you were saying that, Laura, it just reminded me kind of one of the HHS Secretary's priorities is really around patient-centered care and the importance of really addressing the person's needs, not the program needs or what's being driven by the funding stream. And that really sounds like what this is about.
Exactly.
Making the care address all the needs of the person. So I think that's a great step. And as you were talking, both of you, I had a minute in the back of my head to think about other things we didn't cover, and I have to ask about the impact of the opioid epidemic. And I know that within Ryan White program, you're doing amazing work looking at how you can potentially eliminate HCV infection among people living with HIV, because we have an effective cure.
Right. So for years we've been working on hepatitis C for co-infected patients, but previously we had pretty bad treatment that wasn't very effective, and now we've got great treatment where we can cure people. So in the context of the Ryan White program, about 25% of everyone that's in the program is co-infected with hepatitis C and HIV, and we're working hard now to try to cure all those people. In my clinical practice, where we have a lot of capacity because I work in a larger medical center, all of my patients are now cured. Which is just it's fabulous. But other places, they don't necessarily have that capacity. We need to build it. So we are taking a typical Ryan White approach of working with city and state health departments to figure out how to build that capacity, because that is our goal, to cure everyone in the context of the program.
And I think you are going to end up, once again, having the Ryan White program being a leader, not just for HIV treatment, but for treatment as a whole for the country. And I really applaud you for that leadership, Laura.
Well, I have to applaud all the people that are actually doing the work in the communities. It's, we're here getting the money out and setting some visions, but it's really the people that are in the community that are making the difference.
And it is hard work. We
Really
can't
hard
discount that at all. So John, impact of the opioid epidemic on the prevention side of the house?
Well, it's been pretty substantial. 2 years ago, we had an outbreak of over 200 people who got HIV infection in a small community in Indiana, and all of those infections appear to have occurred around within a year of the time that they were diagnosed. So it spread very quickly, like wildfire, through the community. And so we have identified over 200 counties in the U.S. that are vulnerable to a similar outbreak. And a lot of those counties have responded to that by finding, helping people who are injecting drugs get either tested or into medication-assisted therapy, which helps them get off taking drugs, or also putting in syringe service programs, which are these comprehensive programs that not only ensure that people have access to sterile injection equipment, but also do link them to drug treatment, link them to HIV and hepatitis C testing and treatment, and also can sometimes provide naloxone so that folks won't overdose. So the opioid epidemic has really affected the public health infrastructure of our entire society, and we have to respond.
Yeah, and I think it's been a great example of how, when there's a problem, public health responds, governmental leaders respond, and we see now syringe service programs in all kinds of places that 5 years ago would not have allowed them to exist. So I think it's really an important thing to keep in mind that as circumstances change, people can change too. And we have to keep on doing that to respond to the epidemic. So I think with that, we're going to wrap this up and say goodbye to both of you and to our viewers on Facebook Live. Thank you for joining us, and I want to remind everybody that you can always find more information about these issues and everything else related to HIV and the federal response on hiv.gov. Thanks so much, and have a good day.
Thanks, Rich.